Welcome to tonight's program, The Changing Landscape of MRD Testing for Colorectal Cancer, What's New in 2023. Tonight's presenter and discussant is Dr. John Strickler, Associate Professor of Medicine from Duke University, where he is co-director of the Molecular Tumor Board and a PI in many of the colon cancer programs. John, with that, we'll let you go ahead and begin.
Thank you so much. It's a pleasure to be here tonight. And it's a pleasure to join you from North Carolina. I know we've got people dialing in from across the country. Thank you for taking time this evening. So I'm here to talk about the changing landscape of MRD testing. And, I've been using this test in the clinic to some degree. And I think the first thing before we dive into the data behind it is just to talk about what this actually means. What is MRD when we throw this term around so loosely? You'll hear MRD described a number of ways. One way is with molecular residual disease. Some will call it minimal residual disease, but ultimately what we're talking about is the same thing. And that is based on this notion that you can remove a tumor and potentially detect the presence of that residual disease through circulating tumor DNA that originated from that tumor. And there could be potentially a window of opportunity to intervene early or change how you manage that patient based on that result before it becomes clinically detectable, so that you could potentially drive that DNA down to undetectable levels again and the tumor never recurs. So that is the basic idea here. And there are two different types of assays that we have available to us commercially in the clinic. One is this so-called tumor-informed assay, and the second is this plasma-only or blood-only test. Both are available to us. Most of what I'll talk about tonight is around the tumor-informed technology, and the reason I'll focus more on that is that we just have a lot more data around it. I do have a little bit of data to show you on the blood test, but we'll focus on the tumor-informed assay. And I know many of you know this already, but I'll just reiterate it. This is the tumor-informed assay is built, customized from the tumor that is removed from the patient's body. Whole exome sequencing is performed on the tumor, and then 16 unique DNA probes are created that are personalized to that specific tumor. It's not present in germline DNA. It's not present in the myeloid compartment or any other cell of the body. And then you create that custom assay and look for those specific strands of DNA over time. So that's the basic technology here. And actually, it originated from a company that started doing this to pick up Down syndrome, so circulating tumor DNA and maternal bloodstream. So, and then they realized they could apply this to other contexts, like, for example, early detection of cancer. But when you talk about colon cancer, you have an interesting conundrum here for us in the clinic. In patients with stage 3 colon cancer, more than 50% of patients are cured with surgery alone, and yet we give everybody chemotherapy. So we're potentially over-treating some patients. And in the stage 2 setting, standard of care frequently is no adjuvant chemotherapy, and yet 15 to 20% of these patients will recur. So we're potentially under-treating stage 2 patients. And the question is, can we potentially use circulating tumor DNA to be smarter about who we're giving chemotherapy to, giving chemotherapy to people who have high-risk disease independent of their stage, and sparing people the toxicity of chemotherapy where maybe they have lower risk disease. And that's ultimately what will be needed in large prospective trials for this to be fully adopted in the clinic. Until then, we are stuck with the data we have. And fortunately, we do have extensive data. What I want to focus tonight on is the latest data set to be published. And this is the so-called Galaxy study, which comes out of Japan. I think Japan is useful to us for two reasons. First, because they follow treatment algorithms and approaches to the use of adjuvant chemotherapy that are very similar to how we do it in the United States. I spent a lot of time talking to the Japanese, and they seem very closely aligned to our practice. Second reason why I think the Japanese context is important is because they are extraordinarily efficient at generating large amounts of data, large amounts of high quality data that we can digest and review and help inform our own practice. So with that, let's talk about this so-called Galaxy study. Here in Japan, they use the Signatera tumor-informed assay for patients who had resectable early stage colon cancer. Stage 2 or 3 here was the ideal criteria. And they collected blood before surgery, immediately after surgery at 1 month, and then every 3 months all the way up to 5 years. Now, they do have a couple of interventional trials that they have not reported out yet. What I'm going to focus on is the so-called observational experience, where there's no randomization, no assignment based on those results. It's strictly observational. And that's an important caveat as we look at this data. So overall, they enrolled over 1,500 patients in less than a year. There were just over 1,000 patients included in the outcome cohort, the so-called Galaxy cohort, and they divided this into 3 different cohorts of interest. The first is a dynamics analysis cohort where they look at change over time, what happens when samples flip from negative to positive and vice versa. Then they look at a group of 187 patients that are ctDNA positive 4 weeks after surgery, and this is the so-called clearance analysis cohort. And then they look at the group that was negative 4 weeks after surgery, and this is the ctDNA negative cohort. So with that background, I will dive into the results. And I will start first with the prognostic significance of the circulating tumor DNA assay exactly 4 weeks after surgery is completed. So on this Kaplan-Meier curve, and once again, this is all stages using the Signatera tumor-informed assay. In those patients who are ctDNA negative, as shown in blue, 18-month disease-free survival is excellent at 90.5%, but this red line corresponds to those who are positive at the single postoperative time point 4 weeks after surgery, 38% 18-month disease-free survival, tenfold greater risk of recurrence for those who are positive compared to those who are negative. So this establishes, after only 16.7 months of follow-up, so this is an early data set, but it establishes the prognostic significance of this assay. They then took it a step further with a really fascinating analysis where they looked at the impact of giving this group of patients here adjuvant chemotherapy to see how much it helped. So this next analysis looked at those patients who had high-risk stage 2 or stage 3 disease where adjuvant chemotherapy would have been medically indicated. And granted, this was not a randomized study. This is observational. So I don't know why patients got observation in these high-risk categories, but they did. And they found that there was no significant difference in 6-month or 18-month disease-free survival for those who got adjuvant chemotherapy or not, if they were negative at the single postoperative time point. I will point out that there is a numerical difference, small numerical difference between adjuvant chemo and not, but it did not achieve statistical significance. So p-value was 0.16. I think regardless, we can see that there was low benefit to giving somebody who was negative adjuvant chemotherapy. Then they flip the question on its head and look at those patients who are positive at the single postoperative time point. Once again, high-risk stage 2 or stage 3 disease, and ask the question, what happens if you give these high-risk patients adjuvant chemotherapy? And you can see adjuvant chemotherapy, 18-month disease-free survival, 61% compared to 22% for observation. So while chemotherapy did not protect all the patients here, there still was a number of patients that had recurrence. It did appear to support the use of adjuvant chemotherapy in these high-risk ctDNA positive patients. The one caveat I will say, once again, this is patients with high-risk disease getting observation. I don't know why they were placed on observation, may have been due to age or comorbidities, and there were a small number of events. So those are the caveats with this data set. So then they do a fascinating analysis. This is the so-called clearance analysis cohort, where they looked at two points, not just that single postoperative time point, but the 4-week post-op time point followed by the 12-week post-op time point. And they asked the question, what is the prognostic significance of your circulating tumor DNA flipping from negative to negative positive? So best group, 92% disease-free survival if you stay negative at those 2 time points. But if you turn positive at 12 weeks, much worse disease-free survival at 33%. Interestingly, there were some patients who were positive at the first postoperative time point and then flipped to negative, and they did pretty well, 81% disease-free survival. And not surprisingly, that group with the worst 18-month disease-free survival is those who are positive at both time points. Any questions about this data so far? So clearance of circulating tumor DNA appears to be important. And they next looked at this question of how to clear circulating tumor DNA. So they compared those, the rate of clearance for those who were ctDNA, rate of clearance for those who got adjuvant chemotherapy in blue versus didn't in red. And you can see you're 8.5-fold more likely to clear your circulating tumor DNA out if you got adjuvant chemo. Interestingly, there was a very small group of patients who were who cleared their circulating tumor DNA spontaneously with no intervention. I don't know why. It's kind of a curiosity of this paper, and I don't think the authors know why. May have been immune mediated, may have been a trace positive, false positive, I'm not sure, but there were some patients who spontaneously cleared. What is the impact on survival to clear the circulating tumor DNA? This is this next slide, where we can see 11-fold greater risk of recurrence if you fail to clear your circulating tumor DNA. Blue is those patients who cleared, red is those who didn't. 20% 12-month disease-free survival for those who did not clear compared to 85% for those who did. So I hope I'm making the point here that this is a strongly prognostic assay. This is an observational study. I don't think we should make strong conclusions about the utility with respect to use of chemotherapy from this, but it still supports this as a prognostic tool. So with that, I would like to start with Dr. Strauss's case, if that's okay. I don't know if Dr. Strauss is on.
Yep, I'm on.
All right, I'll talk it through here, and you can add any additional details. So this is this is your patient, 63-year-old, no past medical history, came into the ER with severe abdominal pain, ascending colon mass. Colonoscopy shows 2 masses, an ascending colon mass as well as a sigmoid colon mass, 2 primaries. This happens sometimes. Right hemicolectomy was performed, as well as low anterior resection, and the rectosigmoid mass was a T3N0, lower risk stage 2 cancer. The ascending colon mass looked very high risk, T3N2, poorly differentiated. And I put a question mark here. Was this MSI high or microsatellite stable?
Stable.
Okay. I just wondered because the patient had 2 cancers. Sometimes that's a hereditary disorder. But so anyway, the patient received 6 months of adjuvant FOLFOX, went into surveillance. Signatera was first negative, stayed negative. So that's a good sign, but then a whole year later flips to positive. Colonoscopy is negative, CT is negative, PET's negative. Signatera is bouncing around at kind of a low positive and then starts to rise a little bit. And now you've got an MRI of the liver, which shows a questionable abnormality. Biopsy was clear and Signatera is rising. So great question. What did you tell this patient about this result? I'm curious.
Yeah, I chose this case, and I've had patients who've had positive Signataras in surveillance that have ended up being tumors, recurrent disease. But I chose this case because it sort of brings up this, sort of middle patient where the Signatera is positive, and it's hard to know what to tell them. They're probably recurring, but I don't see anything, and they're anxious because they want to do something about it, but I can't treat them. I don't see any disease. I don't have biopsy proven recurrence. Her disease was over a year prior. So we've sort of created this this difficult scenario through our surveillance. So I'm curious if you've had scenarios like this and how you talk to patients about it, because I'm making her quite anxious, obviously. And I don't know what to tell her beyond, she might be recurring, but I can't prove it yet.
Well, I think there's two ways to communicate. One is with the, more at the left brain side of things, the stats and the details, and then there's the emotional component of it, which is and I think many of us find ourselves trying to tailor what we say to the patient based on how they respond. What I want to start first with to answer the question is, what does the data tell us as clinicians about these results? So this is older data set. This was published in JAMA Oncology in 2019, which took several hundred patients in Europe who were tested using the Signatera assay, stage 1 through 3 colon cancer. They found that the Signatera assay was more sensitive than CEA. I forget, was the CEA positive in this case?
No, her CA was negative, I think.
Okay, so it is a more sensitive assay than the CEA. It's also much more specific. How many times have we talked to a patient about a positive CEA that didn't turn out to be cancer? And yet here we see very high risk of recurrence. So for patients who remain ctDNA negative over the long haul, over 3 years, excellent relapse-free survival, nearly 100%. For ctDNA positive, nearly all the patients recur, 43-fold risk of recurrence. So I think it's a question of when, not if, this disease will return. And we already showed the Japanese data for relapse-free survival after that single postoperative time point in stage 1 through 3 colon cancer. We know it's a strongly prognostic assay, but this is really your patient here. These are people who complete adjuvant chemotherapy, and if you're negative after adjuvant chemotherapy, you can see fairly good relapse-free survival, but all the patients in their data set recurred over a short period of time. And in fact, longitudinally, if you're positive at any point in time, the recurrence risk is nearly 100%. And if you remain negative over time, relapse-free survival is extremely good. So I think this is important data. This is out of Europe, showing the mean lead time for recurrence is about 8 to 9 months. That means some people are much longer than that, and some people are much shorter. So it sounds like this is one of these cases where you're picking this up way before you would see it on a scan. And so this is the data out of Signatera. If you stay negative over 3 years, 97% relapse-free survival. If you turn positive at any point during that 3-year stretch, 11% relapse-free survival. Huge difference. And so, what I do when I have cases like this, because occasionally they do come up, they're obviously pretty scary for the patients, understandably. I know that the circulating tumor DNA is most sensitive in certain organ systems. It is by far the most sensitive for liver and lymph node metastases. And that's usually, if you're picking something up well in advance, it's coming out of either a lymph node or the liver. And it sounds like you've been scanning the liver pretty carefully and haven't definitely picked something up yet. Lymph nodes could still be a risk in this case as well. The organ systems that frequently are low shedding and where the test does not perform well for sensitivity is typically lung and peritoneum. So, I don't have an answer here for this particular patient. And Dr. Musa, there's an answer to that question too. I'll save that one to the end, about when to test. But anyway, there's not a good answer, but ideally you do want to pick this up early for the goal of potentially resecting or removing that lesion or treating that lesion. I don't have an answer here. Anyone else have comments on this?
I have a question for you. This is Malik Safa.
Uh-huh.
So, I mean, I understand that you might do that to decide if you are going to give patient adjuvant chemotherapy or not. But I do not know the value about doing it for follow-up if you are going to still rely on the imaging. Why to do this testing and cause anxiety to the patient that your test is positive, but the imaging doesn't show anything? And anyway, you cannot give them more chemotherapy like this patient already got FOLFOX. I mean, I know that deciding on adjuvant chemo, it makes sense for sure, which patient you give them adjuvant chemo, which patient you observe. But to follow up this routinely, I'm not still convinced that it will add too much value.
Yeah, I think the toughest scenario, to your point, the toughest scenario for a Signatera is after somebody's already completed adjuvant chemotherapy. Because to your point, it becomes a prognostic assay, but the patient's just completed cytotoxic chemotherapy. So it puts you in a bind as a clinician. You don't have anything to remove or resect, and the patient's probably developed neuropathy already from the prior FOLFOX. So it is this is one scenario where I think it's just a tough sell to order that test and then to not have a plan. I think it's a great point. And if I do pick it up, then clearly that person goes into an extremely high risk category. The odds are high that that patient will develop recurrent metastatic disease that's radiographically visible. And so it does put them in that high risk category where we're doing more frequent imaging. But let's flip the question a little bit to the opposite now. What if they complete adjuvant chemo and it comes in negative? Could you potentially de-intensify your surveillance? I'm just asking the question.
Yep, that will make sense.
Yeah.
The NCCN gives you like this CT chest, abdomen, pelvis every 6 to 12 months. So I find myself erring on checking scans more on the order of 12 months for the negative patients, and maybe a little bit on the 6-month side. Otherwise.
Yeah, no, I think that's what you're seeing clinicians do, is they're tailoring their surveillance to the risk factors, whether it be that indeterminate pulmonary nodule that you want to keep an eye on, or the CEA is a little bit high, or in the case of ctDNA, that would certainly be cause for intensification of your surveillance. But one scenario that comes up quite frequently is the stage 2 setting. And I bring up the stage 2 setting for a few reasons. The first is because there's actually no clinical trial that has shown a survival advantage to adjuvant chemo for an all-comer stage 2 population. It is a very controversial area for use of chemotherapy, and the NCCN guidelines are recommending that we use prognostic clinicopathologic features to decide whether to give chemotherapy at all. And I've shown here on this slide what some of those features are. Things like lymph node harvest or obstruction, perforation, perineural invasion, vascular invasion. They're telling us that we can use these prognostic features to decide whether to give adjuvant chemo in the stage 2 setting. We also overlay that with patient age, comorbidities. And then the question emerges, well, what about the most powerful prognostic feature we know of right now, which is ctDNA? Should that be part of our decision-making in stage 2? So I'm gonna, before I go into some of the data around stage 2 and this application, am I pronouncing your name right, Dr. Shigdur?
Yes.
Okay.
Yes, doctor. This is my case.
Okay, I think this is a great case.
Can I ask you a question before you go to the second case?
Yeah.
So in the Japanese data, do you know the patient who had negative ctDNA and they recurred, was this local regional recurrence?
I don't know. It may be in that manuscript. They have that manuscript is extraordinarily detailed, and it may be in an appendix.
Okay, thank you.
Let's go over your case. So I think it's a great case. So this is a 61-year-old male presented to the emergency room with anemia. Colonoscopy shows a 5-centimeter mass in the rectosigmoid area. Biopsy shows an MSI high adenocarcinoma. Patient went on to get laparoscopic sigmoid colectomy, T3N0. no evidence of metastatic disease, and you decided no chemotherapy in this case. And I'll show everybody why you decided no chemo in a moment. But 6-month surveillance scan shows a 3.6 centimeter mass near the bladder. CEA is positive now, it's rising, and your biopsy confirms recurrent disease. So the plan is to follow up the molecular testing and possibly resect. So your question is if there's any role on ctDNA testing on stage 2 colon cancer when we do not offer adjuvant chemo. So did you do any circulating tumor DNA in this case?
We didn't.
Do you, if you could do it all over again, would you have done circulating tumor DNA?
I actually don't know the answer.
Yeah. Well, let's go through the stage 2 data and come back to it, because I think it's a really good question. So it's not the latest NCCN guidelines, but I don't think they changed since I put this in here. This is our adjuvant guidelines. So your patient was right here, T3N0. Oh, wait, wrong category.
It's MSI high.
Yeah, your patient was right here, MSI high, observation. You followed the book. They said, don't give adjuvant chemo, even with high-risk features, don't give adjuvant chemo. So you stuck right to the list. But I will point out down here, if the patient was MSS, they say you can either give capecitabine or FOLFOX or observation. And then they have in these footnotes all the different prognostic risk factors you can follow. High risk factors include all these clinical pathologic criteria, but not circulating tumor DNA. They actually specifically called out the use of various panels not to use. So what do we know from the Signatera data, the Galaxy data set from Japan, specific to stage 2 disease? So this is...
They only did high risk. They didn't do the...
This is all stage 2.
Okay.
Yeah, so this is not just high risk. This is low and high risk together. This is the single postoperative time point, 4 weeks post-op. And for those people who are negative, the 18-month disease-free survival is 94%. Those who are positive, it's 34%. 18-fold higher risk of recurrence if it's a positive compared to its negative. So let me ask you a question now. Let's say you had ordered this and it came back positive. How would you have managed this patient differently?
I think I would talk to the patient first and give them the newest data and ask them that if that based on the data that this patient had a very high risk chance of recurrence, even though the guideline, as per the guideline, the chemo is not offered, but based on the statistics, I mean, we can offer the patient more frequent follow-up and also probably do a ctDNA at the beginning and then monitor this ctDNA with CEA and the imaging and see what the patient decide.
So Dr. Alistar, I remember well, she used to be up the road from me before she moved away. But Dr. Alistar, if you were to give this patient something, right, stage 2, T3N0, MSI high, positive circulating tumor DNA, if you were going to give this patient some kind of treatment, what would you give them?
Well, I think it begs the question if we shouldn't use immunotherapy for a patient like this. We know that for stage 2 MSI high 4 years old is detrimental. We don't have the clinical trial to support this, but I think that is what I would consider.
So you're just suggesting that maybe there's a role for immunotherapy in somebody like this. That's a really interesting point. So we have Keynote 177, which is stage 4 MSI high colon cancer. Frontline, pembrolizumab is superior to FOLFOX. So that's our standard of care for an MSI high patient newly diagnosed metastatic disease. We give Pembro, not FOLFOX. So
Dr. Strickler, may I ask one quick question, please, here?
Mhm.
Hey, I know it's not a large study. Last year, around ESCO, there's a presentation of that 14 cases of rectal carcinoma
Yes.
like this, MSI high, neoadjuvant, complete response, 100%. I don't think we should ignore that. And perhaps if medically, if I can get approval, maybe I would consider giving adjuvant, the Jamperel. I know it's off-label indication, but that 14 cases, 100% response in neoadjuvant setting, that made international news.
Well, I can tell you what I would do in this case, and I'm not by any point, I'm by no means claiming that I'm data driven with this, but I think somebody with a positive circulating tumor DNA with stage 2 disease, that cancer is going to come back. I think that you know, these curves are such that the reason why we don't see it be 100% is we just have limited follow-up right here. You know, the mean follow-up time was 16.7 months. I consider someone to have positive circulating tumor DNA to have metastatic disease that's not radiographically visible. I look at Keynote 177 for people with metastatic disease. FOLFOX is inferior to Pembro, and we cure about half our patients with Pembro with MSI high disease in the metastatic setting. I also think that there is strong data to suggest that immunotherapy works better when you give it earlier. I would probably give this person a year of Pembro. I'm with Dr. Alistar on this, but that's just me, and it's not rooted in our algorithms. As you can see, there's nothing about Pembro here. So, but that's just my own take on the data, and I recognize that I'm a bit off the reservation with that point of view.
But there is a study now which has been closed. I think we're going to wait for the data about giving immunotherapy after completing chemotherapy for adjuvant.
Yeah, so that's the cooperative group study where they're doing FOLFOX Atezo versus
Yes.
FOLFOX. Yeah,
Right.
but remember, all those patients are getting FOLFOX. So it's just FOLFOX plus minus.
If I might, I would like to add something, John. So I wonder if we do, you know, with CA sometimes, many times, if I have a rising CA, I have to trend it. I don't necessarily just take one value, you know, to determine absolute recurrence unless it's a really high number. I wonder what is the value of trending the Signatera as well, meaning not reacting to the first positive Signatera, because we are still in the micrometastatic disease theoretically. And I don't know that we have to really be that sort of reactive. I wonder if just trending it first before reacting wouldn't be important. Because what if the patient has a follow-up one, you know, going down, and then I think that it would give you more data points to kind of make your decisions, as opposed to just reacting to one value.
Yeah, I think it's a fair point. Sometimes the kinetics are quite rapid and the growth is rapid, but sometimes we see these kind of bounce around right around at barely the level of detection. If you can somehow manage the patient's anxiety around these numbers, then I think that particularly in a microsatellite stable setting where chemotherapy is of unproven benefit, it's not a bad idea. You know, but I want to get back to the stage 2 question, and this is data that comes to us out of Australia, and the so-called dynamic study. Now, they used a tumor-informed assay. This is not the Signatera assay. This is a different tumor-informed assay, a different proprietary one. All patients had stage 2 disease, both T3 and T4 and 0. All of them had R0 resections, and they were randomized 2-to-1. So by the way, there was 2 blood draws, 4 weeks and 7 weeks post-op. But patients were randomized either to standard management with standard criteria for use of chemotherapy based on clinical pathologic criteria, or ctDNA guided management. Now, if patient was randomized to this group, they only got adjuvant chemotherapy if they were positive. If they were negative, regardless of their high-risk features, they got observation. Primary endpoint is relapse-free survival. And we can see here very interesting. Patients were half as likely to get chemotherapy if they were randomized to ctDNA guided management, so much lower use of adjuvant chemotherapy. But for those patients who did get chemo, it tended to be more aggressive. 62% got an oxaliplatin-based doublet compared to 10% with standard management. So it was more aggressive chemo, but given less frequently. And another important point is those patients who use ctDNA guided management had about a 1-month delay to the start of adjuvant chemotherapy by virtue of the fact that that tissue needed to be collected, sent off for whole exome sequencing, and then the tumor-informed assay needed to be built. Despite that delay, and the lower use of chemotherapy, there was no difference in 2-year relapse-free survival. So this was published in New England Journal last year, also presented at ASCO. So it appears that patients were treated with less chemotherapy, but had same 2-year relapse-free survival. So it's a great prospective study. And many of us live in areas where we are increasingly using this non-operative management protocol for locally advanced rectal cancer, and where active surveillance is part of the management plan, where we're trying to avoid surgery. And so I thought I would throw in this data also from the same Australian group, where they took 200 patients with locally advanced rectal cancer, collected blood before chemoradiation, after chemoradiation, and then after surgery, and looked at the prognostic impact of the assay at those time points. I will point out that ctDNA detection rate was 77% before chemoradiation, 8% after radiation, and then 12% postoperatively. And whether a patient was positive or negative, there was no prognostic impact before the start of treatment. But then after chemoradiation, you see the curves really separate. Those who are negative have a much better relapse-free survival than those who are positive. And then postoperatively, you can see the gap even wider between those who are positive and those who are negative. And interestingly, they also looked at the impact of CEA, and CEA was elevated postoperatively in only 5 out of 22 cases that recurred. So CEA appeared to perform particularly poorly in this locally advanced rectal cancer population. Anyone using this right now, or I should probably start first with, is anyone incorporating non-operative management for rectal cancer in their current practice? And have they used the circulating tumor DNA assay in this way yet?
We have been using observation for patient, but not using the circulating tumor DNA.
Okay. We've had some discussions about it at my institution, and one of the concerns that the surgeons expressed about the non-operative management is that sometimes their exams are either the preps are not clean, or that they can have difficulty visualizing the cancer. So it's actually the surgeons that are asking to include that as part of our non-operative management protocol.
I have a question on one of the on when do you, in your practice, since you use this, do you pull the trigger to give the chemotherapy? If somebody stage 2, is it at 4 weeks mark, or you repeat it again at 8 weeks, or when do you pull the trigger?
I think that the data would suggest that having 2 time points is valuable. So we don't know the optimal time points at which those should be drawn. The data out of ASCO GI suggests that you don't need to wait all the way to 4 weeks to draw that first blood, that you can do the first one at 2 weeks and then maybe another one at 8 weeks, because you need the results back quick enough so that you can actually incorporate it into your decision making. If you do 4 weeks and 12 weeks, I think a 12-week time point is maybe late to wait for that second blood draw.
Yeah.
Dr. Fine.
Yes.
All right, welcome. We're going to talk about your case here. I'll walk it through. So this is a 70-year-old male, stage 3 colorectal cancer, underwent surgery, negative margins, but 3 positive nodes. So this is a stage 3 cancer. Tumor in blood was sent for Signatera. And Then patient received Folfox. Looks like the patient also got cetuximab. And then currently 12 months out from surgery and no evidence of disease. So question, do we prefer the tumor-informed assay over the Guardant assay? Because Natera is tumor-informed while Guardant is not. I can answer the second question. Is it an expanded 360 panel? The answer is no. It is a special assay where they include both common mutations, like 20 to 25 common mutations in colon cancer together with methylation. It's a totally different assay.
Okay.
The Guardant Reveal test. And then what do we recommend for length of time for follow-up with the MRD tests? So the way the studies were done with the tumor-informed assay from Signatera, it was 3 years of follow-up. But I can tell you in my practice that my patients who are negative really love getting great news. So they want to keep going well past 3 years. So, I can understand why they'd feel that way. What are the advantages or disadvantages of using ctDNA versus CTCs? Another great question. As a GI oncologist, I can tell you that CTCs are relatively rare in GI cancer. So the circulating tumor cell technology has never really made it for us just because the technology does not detect them readily. So what I'm going to focus on here is this Guardant Signatera question. We don't have a head-to-head on these two tests, so that is a limitation. All I can show you is what I snipped from a poster at ASCO GI. This is the Guardant Reveal assay, and they looked at a couple of different points. One is this landmark time point, which is immediately after completion of definitive therapy, whether that be surgery or chemotherapy. Sensitivity was at 44%, specificity was good at 93%. So I think there's some worries about the sensitivity off that time point. Longitudinal sensitivity is a little better. These are people who get it serially, and you see the sensitivity goes up. And, I think what this is telling me is you can probably trust a positive, but the negatives, I think I would have concerns about putting too much stock into a negative with this. So I think this is a great time to go into our NCCN guidelines and what they're telling us. NCCN guidelines are conservative, and they make the point that I think has been said on this call tonight. Sounds a lot like a committee member. While these results support circulating tumor DNA as a prognostic marker, details such as timing of the assay and value of quantification of circulating tumor DNA are subject to ongoing studies. Early knowledge of cancer recurrence in the absence of effective interventions could cause significant distress to a patient. Sounds like our case earlier. So the panel believes that there are insufficient data to recommend the use of any of these assays to estimate risk of recurrence or to determine adjuvant therapy, and they are recommending clinical trial enrollment. I feel like, was it Dr. Musa? Were you the one who verbalized some of these points?
I would just asking when is a good time to
Yeah.
Signatera.
And
Well, this is a very good, very, very important point, because we have a lot of patients with positive ctDNA after chemo and surgery, but we do images and we don't see any evidence of malignancy, and patients freak out and we don't know what to do.
absolutely.
I think, if I may add, John, I think the guidelines are going to change as soon as the FDA considers MRD as an endpoint in clinical trials. I think that's really what's going to move the field forward, because then we will have clinical trials that will determine what to do post-adjuvant treatment with a positive test. I think that is coming probably in the very near future and should help us with our patients in this setting.
I agree. So it's impossible. It really is very difficult to develop a drug for someone with stage 2 or stage 3 disease, partially because you need like several thousand patients to show a difference in disease-free survival over 3 years. It's practically impossible to run a study like that. So there are attempts ongoing to potentially use circulating tumor DNA as a surrogate biomarker, as a surrogate endpoint to potentially develop therapies in the earlier line setting. So it's a great point, and I agree that would certainly make this a mainstream test. But you know what we also need on top of this is just prospective data that we can change outcomes for patients by virtue of this data. And there are a number of studies ongoing. We've got this Mass General study, Stand Up to Cancer, where they're taking patients with stage 3 disease. All patients get standard chemo. And then after completion of chemo, patients who are negative get surveillance. Those who are positive are either given a biomarker-directed treatment or they're randomized to surveillance or FOLFIRI. So that's an interesting study that could show the utility of circulating tumor DNA. This is a study that many of us have open at our sites. This is the Circulate US study. I love this study. We hope to open it soon at Duke. This takes low-risk stage 3 disease, T1 through 3 and 1. And if there's no circulating tumor DNA detected, patients are randomized to either standard chemo or surveillance. If there is circulating tumor DNA detected, patients are randomized to either standard chemo or more intense chemo with FOLFOXIRI. And then this will be a joint analysis with Circulate Japan. So this is a really outstanding trial as well. And I suspect some of you, many of you have already enrolled to it. This is NRG-GI-005, the COBRA study. This looks at patients with resected stage 2A colon cancer and randomizes them either to assay-directed therapy or standard of care, which is active surveillance here. So those who get assay-directed therapy only get chemo if they are positive. If you're negative, you don't get chemo. So that's another interesting study. So there's a lot of really great stuff going on here in the field. I think MRD testing is clearly a validated prognostic tool. It's particularly valuable for patients with stage 2 disease. That seems to be where the data is most aligned. But there may be some other niche applications like locally advanced rectal cancer where non-operative management is considered. It might have utility in the stage 3 setting to potentially avoid treatment, but we needed Circulate US to show us that that's possible. And then there are some other applications where many of us are using it, like stage 4 disease. So those patients who have maybe already had FOLFOX chemotherapy, have resection of a metastatic lesion. There's no data that adjuvant chemo provides benefit. Could we use it in that setting? It's possible. We see also people use it where there's a lot of anxiety around an elevated CEA. Sometimes that helps to de-intensify the surveillance in somebody who has maybe a trace positive CEA. So there are prospective trials ongoing to explore the utility of this test, and I think it's a really interesting time. So with that, I will wrap up and answer any questions. I'm going to start with the beginning one, which is when is it a good time to check Signatera? I did not show you the data tonight just out of time, but I would check it as soon as 2 weeks after surgery, because I think that gives you a quicker read on it. And it gives you the opportunity for a second blood draw, maybe 6 to 8 weeks to raise your sensitivity up. So that is my new standard, even though I showed you data with blood draws at 4 weeks. Do I recommend more? We talked about the surveillance scanning question. Okay. Phil asked the question, would this have application in an oligometastatic situation? I have great slides on this, Phil, and I just ran out of time to show you, but yes, all the data I just showed you about the prognostic impact in stage 2 through 3 also applies to stage 4. We don't know that giving chemotherapy changes the long-term outcome, but patients who are negative after resection of a metastatic lesion have a very favorable long-term prognosis, both disease-free and overall survival. So if I'm torn about whether to give chemotherapy in the stage 4 setting after resection of a metastasis, I may consider MRD testing. That's another great scenario. And then once it's positive, do you continue checking the Signatera to assess treatment response. I will say this, it depends on the patient. If it will drive my patient nuts to follow that number out, I will not check it any longer because I need to deal with the emotional needs of that patient. But one of the indications for Signatera is to assess treatment response. And in fact, there is excellent data, which I'm not showing you tonight, that shows that it does track very well with radiographic response, particularly to immunotherapy. So yes, that is another application. Any other questions?
Yeah, one more. There's once you have somebody with you mentioned oligometastatic, but if you had somebody treated with adjuvant therapy, now they recurred with an isolated liver lesion, you resected that liver lesion.
Mhm.
There's a tendency, obviously, to give adjuvant therapy following the resection of that isolated liver lesion. So I think that would be a very good place where the assay would be very helpful in maybe allowing observation or suggesting, adjuvant therapy following what is intended to be a curative resection of an isolated liver mets.
Well, to your point, I agree with you completely. And actually, there is no survival advantage to giving somebody adjuvant chemotherapy following resection of a metastatic lesion. That's been shown both out of the EORTC data and out of JCOGO 603. So it's a problem for us. The patient's already gotten FOLFOX. We know they're high risk. You already resected the liver or the lung met. And so, as I said, this is the Signatera assay in Italy for patients who had stage 4 disease, resection of metastasis. We can see the single postoperative time point, much better disease-free survival for those patients who are negative at the single postoperative time point, and then serially you can see a huge gap. So I think that it is fair game to give someone with this high-risk disease adjuvant chemo because their prognosis is so poor, but that's not been validated. But look at survival. For negative, we would not want to give somebody in this category adjuvant chemo.
Yeah, I totally agree. I think it's a very helpful situation.
Yeah.
When it's now very vague and uncertain.
Yep. Yeah, where we're operating in a data-free environment, sometimes we have to do the best we can with the information we have. We do it all the time. Great. Well, any other questions? Yeah.
For an engaging discussion tonight. I hope everybody found the presentation informative, and until next time, have a pleasant evening.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks a lot.
Thank you. Good night.